Welcome to Neuro Stories, the podcast that highlights the people behind neuroscience at the Walton Centre. Together, we'll lift the lid on the complex worlds of neurology, neurosurgery, and everything in between, hearing fascinating tales of the incredible staff and services carried out in the hospital every day. Hello.
Hello, my name is Dr James Holt, consultant neurologist at the Walton Centre.
So, Dr. Holt, tell me about your given subject. Tell me about neurology.
Well, I was always interested in neuroscience as one of the driving factors that pushed me towards medicine in the first place, although I didn't know for sure that I wanted to do neurology at that point, or even medicine. Certainly I always assumed I'd be more interested in medicine than surgery, just because I'm not very practical and I'm not very good at getting up really, really early.
Well, you're right, the surgeons do get up quite early.
Yeah, they always got up too early, really, and expect other people to get up early. Therefore, I was thinking psychiatry or neurology would be a natural home. I actually did a PhD during my student training, so I did an integrated BSc in neuroscience in my main interest, and then I did a PhD in developmental biology, just because I was more interested in science at that point and saw no hurry to run through training and do clinical medicine, which certainly at that point I found a bit scary because you had to be a responsible person and a serious person, also it seemed. And
how old were you at this point?
Well, I had a year travelling around and working on jobs before I started university. I didn't feel ready to dress up, and it took me years before I got the hang of it. And I realised that medicine and being a doctor is a performance. And like an actor, you put yourself into that role. And then it's not stressful because you're being yourself within that role. But until that point, I was more interested in being a scientist, and you could wear what you want. And it's really when I went back to medicine to finish my medical degree after the PhD and then started doing house jobs that I enjoyed it more than I thought I would. I kept on carrying on thinking, well, I'll see if I can do medicine and MRCP and things like that. And at each hurdle I go, oh, well, I'll see if I can do this next thing. And right. I can always drop out and do psychiatry if it's all too much. I got a neurology job as an SHO, and then it was a case of thinking, would I want to do psychiatry, which I'd always thought about, or go into neurology properly as a registrar? And certainly it was then that I felt I wanted to do neurology more, primarily because I still had that interest in neuroscience, and I felt neurology was more science-based in a way that psychiatry isn't so much, just because there's less you can do. It's more about the mind and the practicalities of managing psychiatric conditions when we don't know much about the underlying neurobiology still.
Neurology is a huge subject. There are so many subspecialties and so many things you can focus on under that banner now. Where do your passions lie?
What always drew me to neuroscience was trying to understand human consciousness, as I think that's one of the great mysteries of life. So I saw it as one of the really big things, and that always drew me, trying to understand why we think, how we think, what's going on. So when it came to doing neurology, you might say, well, then your interest would be in cognitive disorders or higher brain disorders. But actually, I've ended up finding peripheral disorders, particularly of nerve disorders, I found most interesting, because when you're trying to solve puzzles of what's going on neurologically with people with suspected or proven nerve disorders, there's a rich seam of medicine underlying that, which can lead to a variety of different causes of similar presentations. But you can analyze clinical data along with neurophysiology data. So you're bringing together multiple data streams to try and come to an understanding about what's going on with the patient in front of you. So when it came to clinical matters, I've ended up finding nerve disorders more interesting.
And so when you say nerve disorders, what kind of conditions are you talking about there?
I lead the neuromuscular service at the Walton Centre. The most ones we see at the Walton Centre are CIDP, which stands for chronic inflammatory demyelinating polyradiculoneuropathy.
Oh.
It is a mouthful. But it's what I always try and say to students is that if you break these words up, they're not as scary as they sound. So chronic just means it's chronic. Inflammatory means it's immune mediated. Demyelinating tells you about the pathology because the myelin is attacked. And this, of course, is peripheral nerve myelin, because we will get confused when we talk about demyelination. So they think of the central demyelination that occurs in multiple sclerosis, but it can also be a peripheral phenomenon. And then polyradiculoneuropathy. These words are just localizing. So neuropathy means nerve problem. If you say radiculopathy, that means nerve root problem. So it's just descriptive. It's saying where the problem is.
And so those kinds of patients, what's happening to them?
Well, it's such an interesting condition because it really can present in a multitude of different ways. Classically, it presents with tingling and progressive weakness over several months. The acute demyelinating polyneuropathy is Guillain-Barré syndrome.
Oh, right.
And that reaches its worst point within 4 weeks by definition. And people often get confused, and people presenting with CIDP, because people know about Guillain-Barré or GBS, people will say, oh, it's GBS. But if it's been going on for months, it's not GBS. And with CIDP, they often have prominent sensory symptoms, which is less common in GBS. So they may have more tingling and numbness and may develop weakness over a few months. By the time they come to see you, it's usually been going on at least a couple of months and it's still getting worse. So your history is important. Your examination is then very important, because you then will find the patient, as well as maybe some weakness, there might be some distal vibration loss, they may have lost reflexes, and that helps you say, yes, this is definitely the peripheral nervous system, and you might suspect a nerve disorder. You might then go on to arrange nerve conduction studies with our colleagues in neurophysiology, who may then prove that it's a demyelinating polyneuropathy by finding the slowing of the nerve. When they electrocute them, they find that the impulse travels more slowly and tell you this is demyelinating. So you can put all that together and make your diagnosis. It's then not necessarily CIDP in that there are mimics. Being mindful of those and thinking about other conditions is important, but very often if there are no other unusual features, it often ends up being CIDP. And if we make that diagnosis, then we will go on and treat that, often with steroids, sometimes with IVIG, which stands for intravenous immunoglobulin.
What's it like working with patients?
Most people are very pleasant and a pleasure to be looking after and trying to help. And that can be very rewarding if you're actually able to make them better, for sure, and get a good diagnosis and treat them appropriately and see them improve. But I think I'm a bit slow, really. I think that's one thing. Other people are really good at being super, super quick. But that's okay. The good thing about neurology is that you need to be detailed, and so quite good for people who are maybe a bit slow. It's probably why I'm drawn to those things rather than something where you have to be really snappy quick and in, out.
What are your challenges then at work?
There's often been poor neurology training at medical schools, so that people haven't had long enough in neurology. It's been given the same amount of time as another specialty that's far less complex, for example, when we know that 1 in 5 presentations to an emergency department are often neurological. And the fact that it benefits from maybe slowing down a bit and thinking about something where a lot of medicine is all about speed and fast and efficiency. What we can't have is everyone waiting a year to see a neurologist because they may have treatable problems and get irreversible neurological damage from not being seen and treated. So what we're trying to do more of is I've actually dropped a clinic to do more triage, so I can pick out those referrals where I don't think they need to see a neurologist and offer advice and guidance. But I think it's a difficult time, so I think the whole NHS is under strain.
You mentioned education earlier. Is that something that you're passionate about?
I've always really enjoyed teaching, probably gone more into doing research than teaching, so I don't do as much teaching as I did when I started out. But I enjoy teaching, and I think it's really important. So I still do lectures for the junior doctors, but I'm not doing so much teaching of medical students except when they join me in clinic. But yeah, that's something I'd like to do more of again in the future, because that's a very rewarding activity. It's nice trying to get people to understand neurology and the way it works and the approach. And if you've got good students, you can see them do that over time, and that's very pleasing to see.
Okay, Dr. Holt, we're going to do the quick fire round. Are you ready?
Yes.
What would you be if you weren't a neurologist?
Maybe a scientist.
What's your biggest hobby?
Well, I always liked doing amateur dramatics, but I haven't been able to do that very easily. Mature, grown-up life, unfortunately.
So what was your last role? What was your last
I was
performance?
Mr. Twit. I did that in Liverpool. And it was really good fun. I couldn't turn down the opportunity to do Mr. Twit. It was
As in
a
Roald
local
Dahl?
group. Yeah,
Amazing.
yeah. So that was really nice.
Favourite song?
I've been enjoying the music of John Grant recently. I went to see him in concert recently.
Favourite book?
I always say Around the World in 80 Days, but it was a long time ago that I read it. But that's always my stock answer.
Favourite film?
The old cheesy westerns, particularly Clint Eastwood.
Favourite animal?
Well, I suppose I'd have to say cats, just because I've got a cat and I like my cat a lot.
Food you love?
French food I particularly like, but I haven't made it to France for a long, long time.
I feel like there's a to-do list forming.
Yeah, well, I do feel that if you start doing the family thing and have a busy job, your life gets frozen to some extent, culturally.
Yes. Food you hate?
I'm not into fruit. I don't trust it.
Why?
I always got a manky bit of fruit when I was young for my mother in the lunchbox, and trauma of the sour tasting satsumas and apples that I was encouraged to eat. I am eating more fruit now because I'm trying to avoid tastier sweet things.
What advice would you give to your younger self?
I think I'd just say carry on, keep on going.
Who's your hero?
Well, can I say Phileas Fogg for the same reason as the book? I just love the wonderful end where he's run around the world and then announces, "It is I, gentlemen," arriving dead on time. I guess it's because I'm very bad at timekeeping and it's something to aspire to.
Has neurology changed for you over your career so far?
Certainly treatment-wise, we're seeing new changes. So some of the previously untreatable genetic conditions are just starting to get treatments. So because there are so many genetic conditions and every genetic condition will have a different approach to it, it's going to take time, but we're starting to see these treatments. For example, in neuromuscular medicine, we've had some very exciting new treatments. One is for a genetic polyneuropathy called hereditary amyloidosis TTR, which was a fatal condition. You start with tingly feet, but then it progresses and you get involved with the autonomic nerves, you get involved with the heart and develop heart failure and malnutrition because of the autonomic dysfunction in the bowel. People would die within 10 years. But now this new treatment stops the amyloid happening. So it's a normal protein, it's called TTR, and that is prone to making amyloid in normal people, but normally doesn't cause major problems. But if you've got this mutation, then it becomes far more amyloidogenic, and people start developing problems in their 50s and beyond. They may then get forming this abnormal amyloid protein because of the mutation, and building up and damaging nerves and damaging heart tissue. So now you can stop amyloid being formed with this antisense oligonucleotide treatment. That is slowing the progression down dramatically. So people will just stop progressing with this disease. So that's been amazing. And we're going to get more and more of these for rare diseases. There's also another one is spinal muscular atrophy, which is like a very slow motor neuron disease that's genetic. And you can arrest that disease with new treatments that block the mutant protein. This is stopping the disease progressing, so people who take it early will no longer accumulate the severe disability that they used to.
And is more of that kind of molecular level genetic treatments, is that where neurology is heading?
Yeah, that's the big thing. We are seeing new immune mediated treatments because the up to now the treatable neurology has been conditions like CIDP and related condition, another condition, myasthenia gravis, for example. And these are all really big diseases that have immunological treatments. And there are new treatments for those as well coming out, which again, using new technology with antibodies. But the new thing is seeing gene therapy type treatments that are targeting genetic diseases. And
who knows? Are you excited?
Yeah, that's very exciting. And of course, the big thing we're hoping for is the neurodegenerative conditions. Many of us feel that it's not that far away that we'll have treatment for neurodegenerative conditions such as Parkinson's, Alzheimer's, Huntington's disease, which at the moment don't have good treatments. Parkinson's disease has many treatments, but they're symptomatic treatments. They don't stop the disease progressing. That's probably a bit further away, but that's what certainly might be happening in the next person's career and lifetime. Probably, I don't know if it'll happen in mine.
Thanks for listening to Neuro Stories. You can listen to more episodes on Spotify and Apple Podcasts, and you can stay up to date with the latest news and events from the hospital on our social media channels, at the Walton Centre on Facebook and Instagram, and at Walton Centre on X. If you've got any feedback, email the communications team at wcft.communications@nhs.net. This podcast was recorded, edited and hosted by Sam Fleet from the Walton Centre's communications team.